PDA doesn't start at school age. It starts much earlier, often from the first year of life. Parents of PDA children almost universally say, looking back, that they knew something was different from very early on. They just didn't have a word for it yet. This video is for parents of toddlers who sense that something is different, but keep being dismissed. Told it's just the terrible twos. Told they'll grow out of it. Told it's too early to know. If that's you, here's what to actually look for. First, let's be clear about what's different between PDA and typical toddler development, because they overlap in ways that make dismissal easy but missing it costly. The clearest early marker: demand avoidance for things they genuinely want. Typical toddlers resist things they don't want to do. PDA toddlers resist things they were enthusiastic about moments before: the snack they asked for, the game they chose, the activity they initiated. The moment it becomes an expectation, the nervous system resists. The snack they asked for suddenly becomes refused when it's offered. The game they chose becomes a battle when you sit down to play it with them. The activity they requested becomes impossible once it's been named as the plan. This is not stubbornness. This is demand avoidance. The nervous system resisting even its own desires when they become expectations. Extreme need to control the physical environment. Very young PDA children often show intense distress around where objects are placed, who is allowed to touch their things, where people sit in the room. This is not greediness. It is the nervous system managing its environment to reduce the unpredictability that feels threatening. PDA toddlers are often highly verbal and socially engaging, charming, imaginative, articulate for their age. This is one of the reasons they get missed. They don't present as the child who struggles with social connection. But parents often describe a switch, a particular quality of refusal or shutdown that appears around demands, that is distinct from typical toddler behavior. Sleep difficulties are reported very early, often from birth. Difficulty transitioning to sleep, resistance to being put down, frequent night waking, early waking. The demand to sleep and the loss of control that sleep requires is present from the beginning. If your child has always been an extremely difficult sleeper from infancy, that's relevant information. Eating difficulties are common, and these go beyond typical picky eating. It's not just refusing certain foods, it's resistance to mealtimes as a structured event. Sit here, eat this, at this time. Each element is a demand. The mealtime itself is a demand-saturated environment, and the PDA toddler's resistance reflects that. Meltdowns that appear completely disproportionate to the trigger, because the visible trigger is not the real cause. The real cause is accumulated demand pressure, invisible from the outside, completely overwhelming from the inside. The dropped biscuit didn't cause the meltdown. It tipped a nervous system that was already at capacity. Somatic complaints are common and confusing. My legs don't work. I feel sick. I can't do it. I don't know how to put my shoes on. A child who has been putting their own shoes on for months. These are real physical experiences, not performances. When a PDA nervous system is overwhelmed by a demand, it expresses that overwhelm physically. The body is not lying. The nervous system is genuinely dysregulated. PDA in toddlers is regularly dismissed by doctors, by early childhood professionals, sometimes by the other parent. Here's why. All toddlers are like this. They'll grow out of it. It's just a phase. These responses are common because there is genuine overlap between typical toddler behavior and early PDA. The difference is in the intensity, the pervasiveness, and the profile, but those are hard to convey when you're being dismissed in a 10-minute appointment. PDA is not yet recognized in most diagnostic frameworks, particularly in the United States and Canada. Many pediatricians, psychologists, and early childhood clinicians have genuinely never encountered the concept. That is not a reflection of your child. It is a gap in the system. And PDA children are often highly engaging in clinical settings, curious, verbal, cooperative in a novel environment. The assessment context does not show what the home context shows. Parents describe bringing a child to an appointment and watching them perform well for the clinician, then hearing that everything seems fine. It is not fine at home. The clinical setting is different. So what do you actually do if you suspect your toddler is PDA? Document patterns, not incidents. Not a list of individual meltdowns, but the consistent profile over time. What triggers the demand avoidance? What it looks like? How long it lasts? What helps? Clinicians respond to pattern evidence. Keep a note on your phone and log for a few weeks before any appointment. Use specific language when you speak to clinicians, not just difficult or strong-willed. Describe the specific pattern. Demand avoidance that applies even to desired activities. Extreme control needs around the environment. Somatic symptoms around demands. Disproportionate meltdowns after demand. Heavy periods. The more specific you are, the harder it is to dismiss. And you don't need a diagnosis to start helping. Low-demand parenting works for PDA toddlers regardless of whether there is a formal label. Reduce demands where you can. Offer genuine choices. Don't fight battles that don't need to be fought. Give agency wherever possible. The approach helps now, and the evidence you gather in the process supports the case for assessment. Parents of young PDA children, toddlers, preschoolers, children not yet in formal school, are in our Discord community. If you're at the beginning of this and looking for people who've been here, that's where they are. Free Discord community, link in the description. I'll see you in the next video.